Good afternoon, everyone. I'm Dr. Pranita Sahay, and today, thank you. I'll first like to thank AIOS and the Uttarakhand State Society for organizing this wonderful conference and giving us this opportunity. So I'll be talking about the topic OSSN chemotherapy, the way to go. As we all know that OSSN comes in different shapes and sizes. There are different morphological appearance, from diffuse plaque-like appearance, nodular, pigmented, to invasive versions. The investigation of choice always remains impression cytology, and it tells us about the nature of the cells and helps us to identify OSSN. However, with the advent of the AIOSMT and the findings that we have are described in literature, it is one of the non-invasive tools with which we can also identify OSSN. As we all know that the gold standard treatment for OSSN still remains surgery with a no-touch technique. A 3 mm mark is made around the OSSN lesion, and 1.5 to 2 mm mark is made on the limbal side on the cornea, and then with a no-touch technique a peritomy is done. 100% absolute alcohol is applied on the corneal epithelium, following which a simple and easy debridement of the corneal epithelium is done, and with the help of a crescent, a blunt dissection of the tissue or the tumor is removed. It is important that you do not reuse your instruments that you have done to dissect the tissue in the later stages of the surgery, so that you do not inadvertently do tumor seedings to the normal tissue. After the the tumor has been removed, a double freeze thaw cryo is applied on the surrounding adjunct conjunctiva to further freeze and kill the surrounding cells and remove any kind of remaining metaplastic cells if they are present. This is followed by application of the amniotic membrane graft and a BCL application. However, the downside of the surgery remains formation of symblepharon, limbal stem cell deficiency, development of pannus that needs to be taken care of, and that is what led to the advent of chemotherapy in OSSN. We all know that there are various drugs, that is 5-fluorouracil, mitomycin C, interferon alpha 2B, and of late retinoic acid and anti-VEGF has also been tried. But among all these drugs, mitomycin C and interferon alpha 2B remains the two most commonly used drug in our clinical setup. So comparing these three drugs, 5-FU, MMC, and interferon alpha, interferon alpha 2B remains the most preferred drug, predominantly because of its surface-friendly nature, less toxicity. The success rate for all these three drugs, 5-FU, MMC, and interferon, is similar, but the surface-friendly nature and minimal side effects and less recurrence rate as reported in literature leads to it. The surgeons tend to be in favor of interferon alpha. However, the downside is that the drug is little expensive compared to MMC, hence that needs to be taken care of when you're advising this to your patients. Now, this was a survey done in US over 3 decades. 3 surveys were done with similar questionnaire in 2003, 12, and 22, where a paradigm shift was noted in the management of OSSN. While initially management was with predominantly surgery, it has now shifted to topical chemotherapy or a combination of excision with chemotherapy. So you can see that excision alone was 66% preferred treatment choice, while in the recent study, 54% of the surgeons are preferring only topical chemotherapy for less than 2 mm OSSN. For 2 to 8 mm and more than 8 mm also, a shift from surgery to topical chemotherapy has been noted. So let's see few case scenarios. This was around a 62-year-old female who presented with this appearance. Vision being finger counting close to face, this opacity being present for last 6 months to 1 year. And what you see, there's a diffuse nodular appearance of the conjunctiva, and it's not just involving the conjunctiva around 9 o'clock hours, but also invading the cornea. You can see vascularization happening in the cornea, there is epithelial haze, and the lesion is encroaching on the cornea up to the visual axis. So since in such extensive lesions, the surgery leads to limbal stem cell deficiency, so that's not the preferred treatment now. I started the patient on subconjunctival interferon and topical interferon. After first dose of injection and 4 weeks of chemo, this is how the patient looks like. The lesion regressed from 9 o'clock hours to 6 o'clock hours, and the corneal lesion started to subside. The vision improved to 660, although that's not the primary goal of your therapy, but it did improve as the visual axis started to clear up. At 8 weeks, this is how the patient looks like. In 12 weeks, we kept repeating the injection every 4 weeks, and drops were continued till the lesions resolved. We gave 3 injections and continued the patient on topical therapy. This is how the patient looks like 4 months and At now 8 months, the lesion have completely regressed from the conjunctiva as well as the cornea. The vessels that were present also regressed completely, and the vision improved to 6/12 with refraction. So that is the magic of chemotherapy. This is magic of chemotherapy with topical and subconjunctival therapy. So now this is a second case. This was a patient, 9 clock hours of tumor, not as extensive as the last one, but this patient was also HIV positive. In these patients, again, surgery is not what you want to do. We gave the patient injections, and we gave the patient only topical interferon because we wanted to be least invasive in these patients. And this is how the patient looks like at 3 months. It almost regressed, just a focal nodule left over at the limbus with the presence of a pterygium, and we are continuing the patient on topical chemotherapy interferon. The main challenges with chemotherapy management remains compliance, because when you're doing a chemotherapy, you need to see the patient every 3 to 4 weeks and decide upon the need for injection, or if the patient is not improving, you need to decide for surgery. So a good patient compliance and a good counseling before you opt chemotherapy as an option for your OSSN patient is very crucial. Then second is apprehension. As soon as you tell a patient that you have a tumor in the eye and surgery is one of the option, they will want to be tumor free immediately, that surgery kar do and get me off this. So you need to counsel them that there are non-invasive options and which are equally good to deal with the apprehension of the patient. Patience both at the level of the patient as well as the surgeon is important, because it takes time for the treatment to show its effect. Expense, although people say that interferon is just 700 rupees and it's not as expensive, but it's just not the cost of the drug. The number of visits, the overall duration of the treatment, the number of visits that the patient is going to come to you over 3 months and 6 months, all that adds to the cost of the treatment. So you need to look into it, and adverse effect of the drug. So let's see, this is just a 1 clock hour OSSN, an ideal patient for surgery, but the patient was too apprehensive, wanted to go for surgery, and surgical excision was done. Another patient, just a 2 clock hour of lesion, so we could have given him topical and subconjunctival injections, but chemotherapy was not covered in the insurance, and the patient was not willing to pay anything out of his pocket. So he was under some ECHS, CGHS panel. He said, surgery is covered under insurance, you do a surgery for me. We did a surgery, he became tumor free, but ended up with this complication of symblepharon right at the site where we dissected the tumor. So he saved his money, but ended up in a complication. Now lesions like this who are suspicious, pigmented lesion, impression cytology is not giving you a confirmatory diagnosis. In such cases also, you would like to go for excision and as a part of biopsy to confirm your diagnosis rather than jumping directly to chemotherapy. This is another case scenario, one-eyed patient, other eye lost to glaucoma, this eye having a 0.9 cup. Unconventional therapy is not what you want to do. You will go for gold standard. So we did a surgical excision as well as chemotherapy along with the surgical excision, because one-eyed patients, you do not want to take any chances or delay treatment at any cost. So there are multiple studies that have been done with topical and subconjunctival interferon, and they show good results, all over 90% success rate. Recurrence is less than 5%, and hence, to conclude, chemotherapy is a safe treatment option for OSSN. However, a careful patient selection is something which is necessary. Good compliance and close follow-up is key to success in management of these patients. These are my references. Thank you.
Thank you, Dr. Pranita. You have covered every aspect in this.
Thank you, sir.